Today's talk is the project of two-person team, Dr. Jennifer Wang and Dr. Braxton McFarland. Dr. Wang has some clinic duties, so she will not be here during the first part, but she will join us, at least during the discussion session. So the presentation will be given by Dr. McFarland. Okay, Mimi. Okay. He's an MD. He's also an RF in the radiology department. Okay. He works with Dr. Wang. Okay. So this talk is to highlight a project. That how you can work. People in computer science work with people in radiology. Using AI to do work. Okay. So this is going to be a very exciting talk, and we welcome the speaker, Dr. McFarland.
Thank you. Thank you for the warm introduction. So I'll be talking about the opportunities and challenges of AI in radiology. Let's see. It's the arrow to advance the slide, correct? Oh, well, I'll use my laptop. All right, before I dig into my presentation, first give a quick plug for the visiting professor lecture series. Dr. Andrew Smith from UAB will be talking about clinical AI in radiology next Thursday from 5 to 6 p.m. And it's hosted in Pavilion H on the third floor in the radiology department. If you can't attend physically, there's a Zoom link available. I don't have any financial disclosures or conflicts of interest for the material in this presentation. However, Dr. Wang, she does receive grant support from Bunker Hill Health. And this will be the objectives that we discuss in today's presentation. Before I start getting into the details, does anybody recognize this man? Yes. Jeffrey Hinton, about almost a decade ago, basically said a quote that alluded to that radiology would be phased out by the capabilities of artificial intelligence in 5, maybe 10 years. Well, 10 years have almost passed, and while AI has made a lot of progress in its capabilities, it still hasn't replaced radiologists, and radiologist job prospects are still looking pretty good.
Do you know him personally?
I do not know him personally. So radiology is the leader in AI devices that are approved by the FDA, followed with about 75% of devices approved, followed by cardiology. And one of the advantages for radiology being able to have so many devices cleared and interest in AI models developed for radiology is that it deals with a lot of digital imaging versus something like pathology, which could benefit from AI. However, pathology doesn't always have digital images available, so our practice is pretty easily transferable. There aren't currently any generative AI models approved by the FDA, but that's an area that a lot of research is being done. And even though almost 700 devices have been approved by the FDA, very few have been adopted clinically.
What is a device in this context?
So a device, I'll get into that a little later about the most common ones approved, but a lot of it has to deal with handling and processing imaging data or diagnostics. So here are some companies that have FDA-approved medical devices that are powered by AI. And so here's some statistics about the type of devices that are approved. The most common are medical image management and processing systems, which are devices that are related to processing of the imaging data to be reviewed by a medical provider for the purposes of diagnostics. Yeah, that makes up 2/3 of the FDA-approved devices. And as far as anatomy-wise, the highest interest is in the brain, followed by breast. And looking closer into the brain, the most common purpose is for viewing brain anatomy. And here's some statistics just giving an idea about the volume of radiology imaging performed at UK. There's combined almost 500,000 studies between inpatient and outpatient performed every year. There's several machines that we have available to conduct imaging in very many modalities. And each study that's performed, along with the image, there's a free text report that contains the radiologist's summary of findings and annotations that were made on the imaging. And to discuss the workflow of the radiology, how the workflow operates in radiology, it's more than just looking at the image that you get from a CT scan. It actually starts from the order that's received by the physician trying to answer a clinical question, and then that order sent to radiology, where it undergoes protocoling to determine, is this proper? Will this image answer the clinical question? And then, if so, yes, move forward with scheduling. Schedule a patient for conducting a certain type of imaging on whatever machine's available, and if the machine available has the capabilities of answering the clinical question. Then the patient's actually scanned, the image is acquired, and then after the image is acquired, the radiologist interprets the findings from the image. Then they conduct a report and communicate their findings to whoever was requesting the imaging, and then gives a recommendation. Treatment plan is carried out, and depending on the findings in the treatment course, there may be follow-up imaging that occurs later. Within all these steps, there's opportunity for AI to improve this workflow and make it work a little smoother. When it comes to the processing and acquisition of images and processing the data, it's formatted into a DICOM file. And this is a universal standard for packaging the imaging data so that we can use a lot of different imaging modalities, come from different machines, and so they can all be read in a similar format. Within the DICOM data, there's a lot of metadata associated with it about the patient that the scan's performed on and the machine itself, and the parameters of the scan, date and time. There's a lot of data contained within DICOM files, and when performing any sort of research using DICOM data, you make sure that all this data, all the identifying data, is anonymized. And here's some information about the file size of the different images when uncompressed. I mentioned earlier that pathology is another area that could benefit from AI studies done. However, if you notice at the very bottom of the screen is clinical pathology, that their uncompressed file size for their images are a lot larger than what's found in radiology and all the different imaging modalities we use. And I mentioned this briefly earlier, but there's X-ray, ultrasound, there's nuclear imaging, CT, optical imaging, MRI. So there's several different modalities, and we perform these on young and old and scan from head to toe. And I mentioned I showed this graphic earlier, just going over the workflow, and this highlights some of the areas in which AI can improve the workflow. Starting from scheduling, AI can help optimize when and where patients are scheduled for their machines, scheduled for their imaging. When it comes to actual scanning and acquisition of the image itself, it can help improve imaging quality and optimize the parameters for the best imaging quality. Also can opportunity for generative AI to enhance imaging quality. It can assist radiologists with imaging interpretation by recognizing and annotating different concerning findings, or recognizing the normal anatomy, and then from that it can help generate a preliminary report, and assist with the time it takes to do that. Also, it can help facilitate communication or further recommendations that go downstream from actually acquiring the image. And this is just categorizing the ways AI can be applied to radiology. And there's the upstream applications, such as helping with ordering and scheduling the exam. Another area in which you can help is prioritizing the work list for radiologists. And downstream effects would be helping with diagnostics, with disease detection, segmentation of structures of disease, and any clinical prediction of outcomes. And here's an example of the image improvement. So on the left, we have a low signal to noise ratio image that can be produced in about 2 minutes, versus one that's high signal noise ratio, higher quality image. It takes about 8 minutes, but with a deep learning model, it can synthetically produce a higher quality image from the low signal to noise ratio image and have a higher quality image in a lower amount of time. And then I mentioned earlier that AI can help with work list optimization. Now, how work list usually works is, whoever gets scanned first gets read first. There are different priorities for inpatient versus outpatient, or emergencies given the highest priority. But within those 3 classes, it's first come, first read, with computer assistant detection for triage. That's what CAD-T stands for. It can help triage which sort of images have more concerning findings. So instead of being read as first in, first out, images with concerning findings get pushed to the top of the list, or potentially concerning findings get pushed to the top of the list and can be read by the radiologist first. And here's an example of detection and classifying images using ChecksNet. Reads an X-ray image detecting pneumonia, and then it produces a heat map of where the pneumonia is most likely found. And then it's been studied in its performance compared to radiologists, and it's exceeded the average performance of radiologists, and it also has capabilities of other pathologies in addition to detecting pneumonia. Here's another example of detection segmentation using combination of prior imaging. So in cancer detection with AI, it can take in the current image that's scanned along with prior imaging, compare changes that have occurred since the prior imaging, and then use that to detect where high probability of malignancy may lie and how it's progressed. And then here's an example of reducing radiation dose, similar to the example I used with the low signal to noise ratio. Low dose of radiation will produce a lower quality image. However, with AI, the image can be enhanced so you can get a higher quality image with a lower dose of radiation exposed. And I'm going to explore the potential of AI with using a specific indication for breast cancer screening and kind of examine how it's been applied. So breast cancer screening, they've had computer-aided detection since the 90s. However, it's not perfect. It's still a high false negative and false positive rate for breast cancer screening. And the reason why these are an issue because false positives expose patients to unnecessary procedures and anxiety. And false negatives for detecting breast cancer delay the diagnosis and ultimately give patients a worse prognosis. So there was a study done, or a Google Health deep learning model to detect breast cancer from breast cancer screening images. Had a test set developed from the UK and from the US. And these cases were confirmed with biopsy-proven malignancy. And how it performed, there was a reader study performed comparing two different readers retrospectively. So compared to one reader, it showed an improvement as far as detecting breast cancer. And in the second reader, it showed non-inferiority, so on par with another reader. Yes, this is a human reader being a radiologist that reads the study. So in this first initial reader study, it showed that it has potential to surpass the capability of radiologists. And then the second one was done with using the US data. US radiologists, 6 US radiologists detected and annotated malignancy from 500 mammogram images, and their performance was compared to the AI. And again, the AI showed significant improvement compared to the humans, which is good. It shows some promising results. And here's an example of where the AI model outperformed the radiologists, where here is a lesion that was ultimately diagnosed as cancer that 6 radiologists missed in the reader study, and the model was able to detect. However, there was also lesions such as this one where the model misdiagnosed this, and all 6 radiologists were able to detect it. So while there's promising evidence that this can be useful, it's not perfect, and for the near future, it looks like that developing these models be used in assistance with radiologists to supervise the reads.
So what's the reason that an AI can detect something, but those 6 radiologists couldn't?
Sure. There could be several factors as to why or how it's trained, depending, and I'll get into some of the challenges in AI development, one of which could explain why the model missed this. There are several challenges to developing AI. There being ethical issues, poor IT infrastructure, security issues, the bias of models, interpreting the results, inconsistent model performance, AI-human interaction, social acceptance, and clinical integration. So as far as ethical issues go, there's issues about who owns the data. Like, does the data used to train these models, does it belong to the patients? Does it belong to the hospitals? Does it belong to the developers? Are patients giving their data with informed consent? And if there are another issue is like if any adverse events were to take place from a medical decision or medical error influenced by AI, who ultimately takes the blame for that. Poor IT infrastructure. I don't know how many of you have ever worked on projects in the clinical setting, but the hardware and software is not always up to date with what's needed to conduct studies with AI. It can be a challenge to get the proper equipment needed. Also, the electronic medical record and the where the imaging is housed in the PACS system, they don't always communicate very well. And when you're developing AI models that particularly needs data from each system, it's hard when they don't communicate very well. There's security concerns around developing AI, one of which can be around actually building the model. It could be difficult to navigate the security channels to obtain the data. Hospitals are very protective of that data, and on some of the projects I've worked on, it's been quite a challenge getting enough data to train these models. And then there's concerns about actually protecting the data once you have the model set up and used. For those that are not familiar with the clinical setting, there's billions of attempted cyber attacks done on hospitals annually, and of course, with the integration of AI into the clinical setting, and a lot of data being harvested for the use and development of these models, there's going to be of interest of potentially targeting the models to extract data. And also model performance can be hindered by adversarial attacks. Just a quick example, last December, Norton Healthcare in Louisville sent a letter out to almost 3 million patients that their data had been compromised because of a ransomware attack. And there's information, identifying information such as name, birth date, social security number, and a lot of other data that could have been exposed. And as far as adversarial attacks, there was a study done where testing the performance of models and how it can be changed with adversarial data, and it showed that this led to a 69% misdiagnosis for breast cancer in this one particular study. Model bias is an issue, especially when it comes to black box development. It's hard to understand how the conclusions are being drawn. And I think this point may be one of which affected the study I showed you earlier. You asked, how could 6 radiologists detect this cancer, but the AI model missed it when it overall performed better than radiologists. And potentially the bias in the model could be something that exposed that. And when it comes to model bias, are the models being trained on a diverse set of data, and can it be generalizable to a lot of different settings, or does it only work in the setting in which the data came from? And then, is there unconscious or conscious bias within historical data, especially drawing from medical data? There's several instances of how bias has affected medicine, and if you're drawing from historical data, maybe some of those biases are within the context of that data. And then interpreting results, it can be hard to interpret how the models perform when there's a lot of different outputs of saying this is how our model performed, especially coming from the clinical world. Not all of these are outcomes that we use when evaluating performance of things. So when looking at ROC, AUC, precision. The ROC is I'm blanking on that at the moment. I'll get back to you on that question. Yes. But it's a common measure used to measure model performance, as well as precision recall, positive and negative predictive value, and so on. And with all these different measures, it can be difficult to understand and compare different models. And then inconsistent model performance. This was from a study done by Dr. Wang in combination with the computer science department here, when they were developing a deep learning model to detect breast cancer from breast cancer screening images. And they trained their model on this DDSM data set, and the initial performance of it was pretty good, which is represented by this blue line. However, the other three colors were tests of each of the three models on different data sets, and the results were vastly different and underperformed on each three data sets. And then for the concern of human acceptance, both radiologists and patients aren't all on board with AI and where it's going. Only about 30% of radiologists use AI in their practice. And on a survey done of the radiologists, the other 70% didn't have any plans to, or 70% of them didn't have any plans to pay for AI. And 80% see no benefit from using it. And as far as social acceptance, AI tools like ChatGPT and GPT-4 have popularized the concept of AI to the public. But it's also exposed some obvious flaws of it. Here's an example from a query that I did into ChatGPT, just plugging in a relatively simple math problem, and ChatGPT confidently output an answer that is very wrong. When surveying patients on their thoughts, a European study surveying patients on their thoughts and ideas about AI, 58% of them were somewhat aware, most were somewhat aware, and supported the idea of using AI to help diagnose, but would also like to be informed of it. And there are some that are still skeptical of it. Majority of them didn't feel comfortable about AI completely making the diagnosis, and 10% said they would consult another specialist if AI was used at all in diagnosing them. And then issues of clinical integration. Our models that are developed here in the US, do they translate to clinical settings in the rest of the world, and vice versa? There's models developed outside of the US, do they translate to the US clinical setting? Some models, they initially show promising results, but when you use them in studies, but when you use them in more real world clinical settings, they don't perform as well. And then there's an unclear path for how the financial model will work. And so there's research needed for the future of AI, and this is an area in which computer scientists can really help us, is when a lot of AI in radiology uses the imaging data and is used and trained on the imaging data and draws conclusions from the imaging data alone. However, there can be a benefit from using clinical data in combination with the imaging data. Dr. Wang and I are working on a project with Dr. Imran in Dr. Chin, who was formerly here at UK and is now at UAB, on labeling intraoperative images that are taken during a procedure to remove breast cancer. This image is taken, and typically how the process works now is radiologists read this image during a surgery. They communicate with the surgeon and tell them if it looks like there may still be cancer left or it looks good to proceed. And right now, the performance of radiologists isn't great on it. There's a lot of room for improvement, so we're trying to build a model to help detect any changes that maybe the human can't perceive and better predict if cancer is still within this specimen. And in order to do that, we're using a combination of imaging data and data from pathology reports, and it can be difficult to integrate. It can be difficult to integrate all that data together. So one instance in which computer science is helping us sort through the pathology data is natural language processing to be able to go through the pathology reports and extract the information so we can generate more data more quickly. Moving forward, and this is the example of how diagnosis can change when incorporating both imaging data and clinical data. So the first on the left is a list of probable diagnoses just based off of the imaging, and then imaging combined with the clinical information. You can see there's a shift in the probability of what some of the diagnoses may be. Another area of research is, there's not much research done combining both the imaging data and the clinical data. And this, as I pointed out, it can help improve diagnostic quality. Here's a diagram showing literature that's produced annually on deep learning and within medical imaging. The blue bar represents all of the publications that are made related to deep learning with medical imaging, and this little grayish bar, it's the number of studies that are done combining data, or combining clinical and imaging data. And what are some steps that can be done for responsible development of AI? Incorporate an ethics committee and to review the development process to address the ethical concerns. Bring hospital leadership and IT department into the fold so they can assist with creating the infrastructure and the data sharing agreements to make sure that it's done efficiently and securely. Use glass box model development methods so you can audit and verify how the model's performing, and then consider and address as many areas of bias as possible. Also, train and test models on diverse data sets, test model performance in multiple clinical environments, assess model performance with a consistent measure, so we can compare model performances, and then continually vet model performance to make sure that it is working as intended. And then being willing learners of each other's profession. When working with computer science, and my experience working with computer science, I realize I don't know a whole lot about the computer science side, and they don't know as much about the medical side, and then the communication between each other's disciplines has helped us improve the quality of the research that we conduct. And just keeping that channel open, being willing listeners and learning will help improve the models that we develop in the future. And are there any questions? Lingering questions?
Any questions we have?
Are things getting better? Do you expect in 5 years, in 10 years, that in fact the deep learning models will do so much better than the humans that the human will only be there maybe to do every so often a spot check?
I think ultimately that's the goal. I feel like it's hard to predict. It's hard to predict whether, how improvements are going to be made. I think the goal is for the AI to assist radiologists in determining which studies are most important to be read and which ones are have normal or benign findings. So I find it would be hard to have a world very soon where where AI is doing essentially all the work of the radiologists, and then radiologists occasionally check in to make sure it's working properly.
Possibly you will be out of job.
Thank you. Thank you very much for raising up this concern. I'm Dr. Wang, the vice chair of research at the radiology department. I'm sorry I'm running late because I'm still in training today. This is a great question. As radiologists, they always kind of like we do here. Like, 2016 when I was at RSNA, people say that you'll be out of a job in 5 years. How many years from 2016 now, right? So I'm glad that I still have my job, and actually right now it's very hard to recruit radiologists to do this, increasing volume of work. Okay, that's good for us, but I'm still in fear. Why I say that? Because think about ChatGPT. It just popped up last year, right? So quickly, it's just amazing. So there's a lot of uncertainty, and we are very excited about it. I think as a radiologist, have been working with the computer scientists and other, data scientists. I look forward to it. I look forward for the, technique, the new technologies to help us. All right. So you may be a patient. I can ask you a question. Will you trust, this AI to look at your film, make a diagnosis?
Ask me in 20 years.
Right? So everybody can ask, yourself their own question. That's why we're talking about, human acceptance, how patients accept that, how radiologists accept that, right? So if you have some, question about the radiologist's recommendation and the interpretation of your imaging, you can always, pick up the phone, ask the radiologist why you think that. I often in clinic, I talk to my patients. Patients always ask me, Dr. Wang, why do you recommend biopsy for me? Why do you just follow up? I explain to them, can AI do that or not? Maybe in the future, AI can explain to you why they recommend this. If they don't recommend this, what will happen? What are the alternatives over there? I think AI has the potential to do that, but it's still a long way to go because currently most of the AI developed in radiologists, they are just a single task. They can just do one thing. Maybe the AI should be, more comprehensive, do more things for us. Thank you.
Any other questions?
Hello. You bring up understudied hybrid models, and I'm a little confused what two realms they're trying to combine and what the challenges are in both of them independently.
Can you refer back to in the?
You showed a graph of how many publications for hybrid models there were.
Yes. Yes.
What are those hybrid models trying to do that the models aren't doing right now?
So he's at. You can take the question if you want, but he's asking about the combining the clinical with the imaging data.
I don't know about that.
Yeah.
You're talking about the fusion of the is it working? You're talking about the fusion of the data, right? There are multiple ways to do that. Just within radiology fields, we just don't use one single imaging, right? In my practice, I use a mammogram, which is X-ray of the chest, right? And I also use ultrasound. Right now, there's no single modality can combine the mammogram and ultrasound. That's one part of the fusion, right? Another way of the fusion is, use the clinical data. Like, for example, I have a report, right? And then there's an imaging over there. I already reported the imaging, of course, a human language, right? But how to use that to label that and combine this and then generate report. That's a very narrow focus of the fusion of data to build the hybrid AI model. Another way to think about that, out a little bit, out of the box, will be combined pathology results and radiologist results, right? Like people have a joke saying that many years ago, they can train pigeon to read the pathology imaging. I think AI is smarter than that. Maybe they can train, this AI to read both pathology and radiology imaging and generate a report, right? Again, step back, zoom out. Maybe you can combine the clinical data, right? Longitudinally, like 10 years, how this cancer will behave in 10 years based on the clinical information, pathology and radiology imaging. Can we do that? There's a lot of things we can do. Do I answer your question?
You're asking good questions for good research, so thank you.
Yeah, thank you.
Anyone else?
Any other questions?
Yeah, so y'all alluded to kind of one of the big roles of a radiologist right now is explaining things to patients and stuff. And in your flow chart of the radiology process, there's the part about writing the report, which I'm sure is very important. I know with ChatGPT, you can say, summarize this website for me or something like that. And I'm just curious, is there any research right now in basically generative AI where you give it the image and then it summarizes, this is, I don't know, what the doctor needs or the patient needs from this image?
This is a wonderful, wonderful question. I wish there is some AI can be applied into radiology. There are not many research going on. There are some, but not many going on right now. Like every day, I spend so much time just review patient's chart. Get into the EMR system, which is EPIC, I need to read pages and pages of a patient's information. Those things, I think AI can do it. Like with training, AI should be able to provide, the relevant information for me as a breast radiologist. But unfortunately, there are not many research going on. I really wish that, more computer scientists, especially young generation, are interested in this, applied, AI. I know maybe you guys are very smart at, model building, computation. But if you are interested in, application, like in medicine, there's lots of potential can help us and help, patient care. Thank you.
Any other questions?
How expensive are these devices? Pick one device, tell us what it does and how much it costs.
It is a lot. So first, let's step back a little bit. Talking about the device has already been cleared by the FDA, right? A lot of device, even though it has been cleared by the FDA, still not adopted in the clinic. There are multiple reasons, like radiological acceptance, or there's another reason is about money. Who is going to pay that? How much are we going to pay that, right? Just for example, you need to present, radiologists and the administrators about the data. When you want us to adopt your AI in our system, we need to ask you data. What are the clinical trial? Clinical trial just costs so much. It just burn money itself. And then you need to go to, generate a CPT code. so that every time you use that, you can generate money. And then who is going to pay that? A lot of question about that. Currently, for as a breast radiologist, for the mammogram I'm reading right now, we use the CAT. But this CAT is not AI-based CAT. It's just conventional machine learning CAT. That CAT, I think we are paying about, for each imaging, I did this kind of like economical analysis before. If I remember correctly, still, I think CMS is a Medicaid system. They pay, the health insurance company pay about, I think it's 15 to 30 per study. I need to double check that. It's quite a big money.
$15?
$15. Approximately that. I can double check that. That's my number right now.
So you pay per use, you don't pay per device.
That's the one way to do that. You can also pay by, device. You can also pay how many cases you are using.
Did she answer your question?
I think so.
Yeah, it's just very complicated the way. Depends on who is going to pay that, how they negotiate, with the whole system.
We still have time. My personal opinion is that if the equipment is right and if AI is powerful enough, then I don't need those. We don't need those radiologists anymore. Anybody with ChatGPT can function as a radiologist. But I don't know if that time is here yet. So computer scientists are very important.
Yeah, but it's okay. I hope by that time I will retire. Ready?
Any questions? Very interesting topic.
So one little thing is I don't really trust any doctor, and I don't trust any of these systems either. So I've seen too many things get misidentified, etc. So there's always the idea of getting a second opinion. And I think one of the dangers in AI is if all the AIs are trained from the same data sets, because it's hard to get these data sets available, you may not really get a second opinion out of the AI. If you go to another service, you might be using the same exact AI system, and you're checking the thing against itself. So is there anything that can be done on that?
Yeah, exactly. That's the research I did with Dr. Nathan Jacob before, just to show that, the model performed very well on one data set, may not behave well on another data set. We test that, right? And we publish that. And the journal editor kind of like told me at the RSNA meeting, our professional meeting, said that, hey, lots of people quote that. Yes, that is a concern. That is why, before we adopt the AI device in our practice, we need to calibrate. We need to prove that it works in our population, right, first. And also, we need to monitor that to see if the AI's performance will change while we use that. I believe you guys already know, there's another research hot topic on AI is continuous learning, right? Yeah, there's lots of uncertainties we can working on.
While thinking about asking some questions, don't forget to sign in before you take the pizza. That's very important for us.
Yeah, next week we will have two speakers from the industry and also going to give a lecture for us on the AIE radiologists. If you allow, I can send you the information. I will invite all of you to join us either on site or online to stimulate this